Hi, good afternoon, everyone. Thank you so much for joining in. This is our May 1st Commission on Public Health meeting. And we are in the throes of reviewing and adopting recommendations submitted to the commission from each of its 5 work groups. We have quite a significant lineup of recommendations to consider today. So we'll move through some of the business items more quickly. I'm calling the meeting to order at this point in time. And just to note, this meeting is being recorded, so your continuing participation is your consent for that video audio recording, which will be publicly posted on the commission's website later. Shane is going to conduct a roll call so we can determine if we have current quorum. I know we have a couple of commissioners on their way, but we'll see where we are at this point in time.
Michelle will go ahead and do the
okay. Michelle will do the roll call, actually.
Sure. When I call your name, please respond with here or present. Delegate Heather Bagnall.
Here.
Neil Blake Fall. Grant.
Here.
Michelle, I see Camille on.
Oh, sorry.
Camille, are you, is your audio? She's connecting the audio.
Okay, got it. All right, thank you. Dr. Mina Brewster.
I'm here, thank you.
Jean Drummond. Senator Clarence Lamb. Dr. Matthew Levy.
Here.
I would still call her name.
Deputy Secretary Alyssa Lord. Dr. Boris Lushniak. Deputy Secretary Nilesh Kalyana-Raman.
Present.
Dr. Oluwatosin Alateju.
I'm with you. Here, thanks.
Dr. Mara Rothman.
Present.
Dr. Nicole Rochester.
Present.
Michelle Spencer.
Present.
And Ellen Twigg.
Here.
We have a quorum.
Okay, great. So thank you, Michelle, for establishing quorum. I want to draw your attention to the agenda for today's meeting, and that was sent ahead of time to the commissioners and is published online for those who may currently have access. I'll take a motion for approving the agenda. If anybody wants to.
I move.
Thank you, Tosin moves. Any seconds?
Second.
Thank you. All in favor of approving the agenda for today's meeting? You could
Second.
say aye in the room. Thank you.
Aye.
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 I think any nays or abstentions on the agenda? Great, thank you. And before we move to the next item, just want to acknowledge Dr. Lamb, Clarence Lamb, who's joined us, Senator Lamb, and Dr. Boris Lushniak, who's joined us as well from the commission. And I believe Camille Blake Fall was joining in at the time that we were taking, or her audio was joining in. Camille, are you on currently? I can't tell if she. Okay, sounds good. So, all right, thank you. And now next we'll move on to review of the minutes from the April 15th meeting. If you could review the minutes that were sent out in advance and are posted online, and if there's any motions for approval, we'll go ahead and take those. Any second on the approval?
Second.
Thank you. All in favor?
Aye.
Aye.
Abstention. All abstain.
I'm abstaining. I apologize. I have not had a chance to review the minutes.
Thank you.
This is Nicole. Nicole.
Oh, great, thank you. Any other abstentions? Okay, any nays? Okay, thank you. Motion carried. Thank you. All right, we're going to move over to commission updates. So I'll hand it over to Shane, who'll be discussing our timeline and some upcoming matters related to the commission. Thank you, Shane.
Next slide, please. Yeah, there we go. So our timeline now has all simply remaining activities and monthly meetings displayed here. So we really are entering the last segment of work for this group here, particularly as we look towards May 20th in getting the first draft of recommendations in. We're really hopeful that work groups are able to get those in by the 16th, so that we're able to get those out to commissioners with ample time to review. That's been challenging with the multiple work group meetings back to back. But again, I'll make that plug or ask that we're able to get those out as early as possible. We had hoped to get the DBM secretary to speak at one of the May meetings, but we've not yet been able to secure that. I will again make outreach to her office to see if we're able to schedule her at one of the upcoming meetings as one of the final individuals from the statute that we were tasked to get input from. Although I will note our assessment team at the University of Maryland and Morgan State were able to interview some folks at DBM, but we want to make sure that we have an opportunity for a higher level discussion there. Again, a reminder that the June 5th meeting, we will focus almost entirely on our slate of recommendations. So that will be an opportunity for us to bring up all those recommendations for discussion again, to make sure that they are the right format, that we haven't missed something, that we don't have duplicates. That's great. And begin to kind of group things together and see what may or may not be missing. In that review, it may be determined that an additional recommendation is needed in order to address something that has been missing, but the reason that we're really asking for the last batch of recommendations to come in by May 16th is so that we could start to do that analysis behind the scenes earlier than later, with the hopes of June 5th really being more of that review versus brand new content. The importance of that is that we need to have our draft recommendations posted for 30 days in order to meet the statutory requirement for public comment. And we'll be developing a framework for that and bringing that forward to the commissioners for review. But that 30-day comment period will allow stakeholders, work group members, and others to kind of engage, as well as the public writ large. So what we have on June 5th is not necessarily what the recommendations will look like by the end of summer. Looking towards the end of summer, our current schedule has us with our final meeting on September 11th, and the report being submitted to the legislature and executive branch in October, on October 1st, or by that date. And so if we go to the next slide, I want to focus on that month in particular, because as we've been finalizing a couple open items with respect to our assessment team's refinement of their report and onboarding the technical writer for the final report and the graphics folks who will be working on that, our ideal timeline would actually have us doing our final vote and review on the final report around September 25th. So what I am proposing for the group and would like to have some discussion on is that we change that September 11th meeting to virtual only and still hold the time in case we need it. And candidly, that's based on how the interim report went through a couple iterations there. If we don't need that September 11th meeting, we could cancel it. But having our final in-person meeting and the final report adoption occurring on Thursday, September 25th, so that we are able to maximize that last bit of time for edits and refinement, and the commissioners get a say that's a little bit closer to the due date there. So I don't know if folks want to take a moment to check their calendars and see if that would be problematic.
1 to 3 time frames, or sorry, 2 to 5 time frames
I had expected it to be like 2 to 5.
for September 25th. Okay, so what Shane's recommending is holding September 11th for a possible virtual meeting, but changing the final in-person meeting to September 25th from 2 to 5 p.m. So if anybody wants to make a motion on that, we can consider that.
So moved.
Okay, great. Have a
A second from Boris.
great. Second. So let's take if there's any discussion on that or any questions about that. All right. Hearing none, let's go ahead and take a vote. All in the room for commissioners, if you could just say aye if you're accepting of moving it to the 25th
Aye.
as an in-person. Okay. Now online, if you could voice your A's and I's and we'll take nays and abstentions if necessary.
Aye.
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 Great, thank you. Any nays from the commissioners online? Any abstention? Okay, all right, motion carries. Thank you so much, and thanks Shane for recognizing that need.
Okay, so next we have submissions for review, and I put together a slide that kind of goes over the framework we talked about, but
Sure.
you'll-
Absolutely. All right. Thank you so much. We are making great time. It is 2:15. However, we're cognizant that our work groups have been doing some stellar work and putting in a lot of time and effort, including some late night, early morning hours, Brian, to get these work group recommendations out to the commission. So thank you to everyone who has been working on these work groups. Thank you to everybody who's joining in this meeting who has a member of a work group, if not a commissioner. Really appreciate all that work. That means we have 23 recommendations to review today in the remaining 2 hours and 45 minutes or so, and hopefully we get time for a break within that. Given the the desire to afford discussion time for the recommendations where people may have questions or may have concerns or really just might want to discuss, I wanted to propose to the commissioners that we today, our approach be that we see the recommendations proposed by each work group. And if everybody's fine with the recommendations as is, then they don't need any pulled out. We vote on those recommendations to be moved forward to the June slate, which is when we actually as a commission adopt those recommendations for the public comment period. If there are specific recommendations that people have questions about or feel necessitate discussion or might not agree with or would like to abstain on, we can pull those recommendations out from the consent table for that work group, vote on the remaining that everybody would be fine moving forward without discussion, and then come back to the ones pulled out on an individual discussion and individual vote basis. We're hoping an approach like this would help us identify how much time we have to really focus on the recommendations that need discussion, so we don't shortchange the ones that might need more discussion later on. So, but I don't want to, this is a little bit different than how we've been handling it the past couple meetings. So we wanted to make sure the commissioners were okay with that approach. If there's anybody not okay with that approach, please say so, because we'll just revert to the approach of reviewing every single one individually at 23 recommendations. And if we don't finish them all today, then it just stacks up our next meeting, which, by the way, the next meeting is the last meeting where we're actually considering new proposed recommendations. Let me just ask if there's any commissioners who would prefer the old school approach, or if you're okay with the idea of doing the consent agenda and pulling out recommendations that might warrant questions, discussion, debate, abstention votes or nay votes, then we'll pull those out and consider those individually. Is everybody okay with that idea? Is anybody not okay with it? How about in the room? Or are we not taking an official vote here, but is everybody okay in the room? Okay. Online, for the commissioners online, are there any commissioners online that are not okay with that approach? Okay. Hearing none, we'll try this, and then if we seem to be running into a spot where it's getting uncomfortable, then we'll just revert back to the original order. So thank you for allowing that slight process change for today's meeting. All right, so then I'm going to ask Shane to go and through work group by work group, present the summary table of all the recommendations forwarded for our consideration today by each work group. And then we'll pull out the ones that we would like additional discussion around, or nays or abstentions or debate. And then once we get through the 5 work groups and all the pull-out actions, we'll go back and we'll review all the pull-out items individually. All right, does that sound all right, Shane? Great, thank you.
Okay, next slide.
Okay.
As a reminder, our 3 options other than abstention are to advance to the slate, recommit it to the work group, or to vote that the commission cannot support it. Those are what the options will be on the poll, in addition to a 4th option of abstaining in the event that for some reason you're unable to select one of the other options. So moving forward, we will begin with the communications and public engagement work group. The first recommendation is CPE 001, plain language public health information. This is a resubmission from an earlier version, and the recommendation is to ensure that all public information shared by Maryland state and local agencies use plain language in accordance with Maryland laws and executive orders, and funding should be made available for public agencies, especially the Maryland Department of Health and local health departments, to support dedicated access to plain language experts and contracts.
Would be good for some of the summary table, or just do individual? How do you?
I have a summary table when we get to the voting.
That sounds good.
The next recommendation is CPE 002, language access for public health information programs and services. This is to ensure that all public information shared by Maryland state and local agencies are in accordance with Maryland laws and executive orders on language access, and funding should be made available for public agencies, especially the Maryland Department of Health and local health departments, to support dedicated translation and interpretation services to increase bilingual, multilingual staff in health departments. Next slide. DPE 003 is public feedback on public health information, programs, and services. This recommendation is to ensure that health departments engage in ongoing bidirectional feedback with the public, and funding should be made available for concerted and documented feedback on public health information, programs, and services. Next slide. CPE 004, public information officers and local health departments. This is to ensure that communities are informed and prepared to understand and act on public health information, programs, and services. And each local health department must have a full-time dedicated public information officer. Next slide. CPE 005, Health Communications Tools Modernization. Recommendation is that funding should be made available to strengthen communication capacity across local health departments to promote dissemination of health communications materials and health communications materials to the public and enhance delivery through modernized tools and platforms, with a note from the work group that further investigation and research may be needed to determine modernization needs. Next slide. CPE 018, Community Health Needs Assessment Support. This recommendation is to reduce duplication of efforts in completing community health needs assessments, align priorities, and improve implementation of community health strategies. Funding should be made available to support hiring full-time staff, specifically naming the local health improvement, including the local health improvement coordinator or a coalition director, the community health needs assessment coordinator, public health program coordinator, community engagement specialist, or health equity coordinator, and securing necessary resources for local health departments to effectively collaborate with local hospitals, nonprofit hospitals, or community health centers in completing and utilizing data from community health needs assessments. The final submission from the Communications and Public Engagement Work Group is CPE 019, Increased Health Literacy.
Sorry, 1 second. Michelle, do you mind going back? Slide. Thank you. No worries, no worries. Thank you.
Increased health literacy through youth education. This recommendation is to establish a pediatric public health education task force composed of educators, pediatricians, public health professionals, and curriculum designers. This task force will develop age-appropriate standards aligned and culturally relevant public health curricula for K-12 students, focusing on topics like disease prevention, health equity, communication, and critical thinking. The purpose of this recommendation is to increase familiarity with and literacy of public health concepts in students so that as adults, community members will have improved understanding of personal and public health and also inspiration for joining the public health workforce. Do we want to pull them
So
out by work group or?
well, I think we're just going to do the work group at a time. Yeah, so if you have the summary slide, we'll look at the, Dr. Levy, in a moment, we're going to pull up the summary table. And then at that point, if there's any recommendations that require comments or questions, or have anybody who's interested in abstaining or declining a vote, we'll pull those from the consent agenda for the work group.
Sure. I missed a few. Sorry.
Oh, that's okay. That's cool. Yeah. Let's give us a minute and we'll have this table ready for you. While we're waiting for Shane to get that together for us, just want to acknowledge and thank the Prince George's County Government and Prince George's County Health Department for again hosting our commission meeting today, and also to the University of Maryland School of Public Health for providing the snacks for those in the room, as well as Prince George's County Government for supporting that as well. So thank you very much. I know this has been a long-running commitment to support these meetings, but we really appreciate that the space and technical assistance has been made available for these meetings. Thank you. I also want to, I didn't in the beginning since we were kind of starting off quickly, but Tosin Olateju or Sloshniak are 2 additional co-chairs for the commission. Just want to thank them for their leadership. I know they've been leading most of the meetings we've been having here lately. So appreciate that. And I wasn't part of the meeting in April. Unfortunately, I was out of the country, so I wasn't able to participate, but in reviewing that by video, I was really impressed with how well the process seemed to go at the last meeting. So thank you. Great, thank you. So these are the 7 recommendations that come from the Communications and Public Engagement Work Group.
Can I raise an item of confusion?
Yes, Rosalie, go ahead, but just to be clear, like for the remainder of the meeting, we're really trying to keep it to the commissioner comments, but since this is a point of clarification, please go ahead.
Yeah, it says here CPE 005 Health Communications Tools Modernization, but in the submission tracker that came with the meeting materials, number 5 is something else, and I can't find a separate item for Health Communications Tools Modernization.
Thank you for bringing that to our awareness. We'll have to look at that, and we might need a minute or two to figure all that out. But for the commissioners who are on, I think Shane went through the actual language of the recommendation that we would be voting on. So now's the time that if you would like to pull any of these for individual discussion and voting, please chime up, commissioners, and we'll pull those. And if there's any left, those are the ones we'll vote on to move to the June agenda. I'll take any, I see Delegate Bagnall's hand up.
Thank you very much. And this is, again, just a point of clarification, because I think we did during the session touch on the plain language support and language access support. But I don't have a lot of clarity in terms of where the funding landed. So if we're voting on it, we're voting simply to move this forward. So if we have done pieces of it, that would still not run afoul of this process. Is that correct?
Yeah, actually, thank you for raising that question. Let me just clarify. What we're voting on today is to move it to the June agenda, where we adopt in whole the recommendations of the commissioners that approved to move to public comment. After which period we may end up doing some edits to the recommendations depending on the comments that come in during that public comment period. But
thank you very much.
Yes, absolutely. And if you would like to have any discussion around those 2 recommendations that you mentioned, Delegate, then what we would do is just pull them from this consent agenda here and then talk about them later on in today's meeting and vote on them individually. Would you
Thank
like
you very much.
that individual discussion and vote?
I think we're okay keeping them on the agenda, because again, if we're moving them to the June meeting, we can have further discussion when we see what we actually have addressed in the session and what remains to be addressed, if that makes sense.
Yes, absolutely. Thank you. Okay. I'm sorry. If Michelle or Shane could let me know. I'm not in the meeting, so I can't see who might have their hands up. Okay. All right. Dr. Kalyan-Naraman.
I thought I knew what my comments was, but now I'm following up Delegate Bagnall. So just to make sure I'm clear, what are we voting on?
So right now we're just this is the new process and that we're using for today, given the high volume of recommendation. Right now we are just pulling out recommendations from this group that you see on the screen that you would like to individually discuss and vote upon. The other ones that remain, after we've pulled out the ones that we would like to individually discuss and vote upon, the ones remaining we can vote upon to possibly move to the June agenda and for adoption as a final recommendation.
So hearing that, I think numbers 4, 18, and 19 warrant discussion.
All right, so 4, 18, and 19. Thank you. So that leaves 1, 2, 3, and 5. Do any of the commissioners online or in person want to pull from the consent voting 1, 2, 3, or 5?
This is Maura. My hand is up. I guess the wording of all of them seem to have funding. I would just like to clarify, is that new funding? Because there is funding available, so I want it to be meaningful, right? like funding be made available? We could say core is available. Or are you talking about new funding?
I believe the work group in their rationale for the statements identified the kind of new funding that would be needed for this.
Well, then then maybe it's worth discussion to put in new so that we know exactly what,
Right.
that is. Thanks.
Okay, thank you. So
Sorry, I just wanted to touch, and some of them could be to prioritize existing funding. Because yeah,
all right.
it
Then,
just
then
then
we would need
at the
clarification
final
from the
exactly.
work group.
It just
Okay, so if that's the case, are we pulling all of them from the consent agenda for that individual discussion on the funding aspect of each recommendation? 1, 2, 1 and
The-
2.
The one about the public health information officer, I mean, of course, that will require that. That didn't specifically state funding in at least not in the summary, but I would imagine that's going to require funding.
Thank you. Okay.
He has his hand up.
All right, Dr. Levy, thank you.
Yeah, good, good afternoon, everyone. Sorry I'm not there today in person, even though it's in my county. I had just some more clarifying questions. The plain language or the language access, we need to put in there somewhere about ADA compliance with information, so that it's low visual impairment and things like that. So it has to be. I think we should put somewhere in there the language access is ADA compliant. So that's my first comment. That I guess that would be CPE either 1 or 2, or both. And then my other comment is about CPE 19, which is, I don't know why we're just focusing on, maybe there's another one in the list, but I don't know why we're just focusing on health literacy for the youth. I think there's a.
Right now, we're just determining which ones are going to move on to the consent agenda, but we are going to consider that specific recommendation and have discussion with the comments specific to the recommendation in a moment.
Okay.
So if you could hold that thought, but it sounds like so far that we've pulled all but 3 and, well, I think 5 was pulled also.
Rosalie mentioned it, but I don't see that discrepancy.
I thought that was one of them.
And I would say, given the questions raised regarding funding, unfortunately, 3, we probably need to pull as well, because 3 also addresses funding.
Okay, well then let's, so we're gonna go through these individually and have individual votes and discussions. Now, this is probably the largest group, I think, of recommendations in front of us from a work group today. So if you'd like, we can just do those direct and then get to the other work groups, since now we have them fresh in our mind, rather than go through all of them as we had originally intended.
Okay.
If you're okay with that, since we have, otherwise we'll have to repeat going through each individual, refreshing it in everybody's mind. So let's go back through the slides and we'll go through each individual one. And Michelle, if you wouldn't mind going to the slide with the first recommendation from the CPE work group. I think. All set. No worries, thank you. We're just pulling it back up.
No, go back to CPE 001 slide 11.
plain language.
Yeah, there we go. Thank you. If you could put that in, will it go in presenter mode so that it's a little larger? Thank you. All right, so we'll go to. Great. Thank you. Okay. All right, so plain language, public health information. Shane had read out the recommendation. Commissioners, you've received information electronically with the rationale from the work group. describing the thought process behind the recommendation. And we can do discussion after motion. Or we can do discussion first and then actually we're doing the poll, right? So we'll do discussion first and then we'll move to a poll. So let's go ahead and open up the floor if there's any comments for discussion on this recommendation.
Yeah, Boris Lushniak, Commissioner. It seems like we're going to have a common thread regarding the aspects of funding on many aspects of this. And I guess I'll turn to the kind of the funding experts in the room who are commissioners, and that's our dear delegate and our dear senator. Is ultimately this report is going to go somewhere, right? What language is most effective? And you know, what we're not doing here is obviously committing from either of you that there's going to be funding and you're going to be the sponsors of this funding. We're not doing that. But I would like to hear from you, what's the terminology we should be using here, right? In terms of funding, right? Because we know that, you know, in general, you mentioned funding in this fiscal scenario, there's going to be a little bit of dyspepsia for many people. But how is it that we be effective, but basically also denote that the commission has said this, in our view, this is a need and someone needs to look at how we're going to be able to do this. Over.
So happy to share some initial thoughts. So I think
Senator Lamb.
Sure. Oh, sorry.
They may not be with you.
So funding, you know, one is tough, but funding is also a reflection of our priorities. It's even though it's not a policy, so to speak, you know, where you put your limited funds are a reflection of it's really kind of a policy decision, reflection of your priorities as a state, as a legislature. And so, you know, I guess my suggestion to you all and the commission is you know, to scope out and make a recommendation in what you would think is ideal. So if you think there's a need for new funding for, you know, public information officer, just making this up based on one of the other ones, then I think you should make a recommendation based on what you believe should be ideal. Because, you know, everything in the legislature is obviously a compromise. And so we're going to be balancing the decision of this policy priority versus that funding aspect. But at least we know what the ideal recommendation coming out of the commission is. If you give us a compromise recommendation already, it's just going to get compromised even more, you know, as part of the legislative process. So just kind of my thought on it.
Any reflection, now I'll continue, Delegate Bagnell, any reflections from your perspective? And specifically, I'm looking at the wording. In other words, are we ready to adopt something as generic that will fit in, that funding should be made available? Is that enough? Or do we have to specify funding should be made available or continued, right? If there's, you know, regarding the aspects of new versus old funding, et cetera. You know, I like this wording, funding should be made available, because it in essence doesn't presume that there's no funding, you know, but it should be continued to be available, et cetera, however we look at it.
Right, and I appreciate that, and to Senator Lamb's point, it kind of depends, because, you know, obviously these recommendations will then some will be through regs, some will be through bills. If it's legislation, there will be a legislative analysis for the fiscal impact. So I think the question to your point is, this is, I think you're looking for dedicated funding should be made available or continued, because we have had some funding that has been allocated based on the legislative analysis of what it would cost to do some of these initiatives. Now, when you're talking about staffing, I think that is where, you know, when you're creating these specific positions, that is where you might want to look at the specificity of the language, because then it's going to be an appropriation as opposed to, you know, adequate funding to implement the policy. You need an appropriation to ensure that this position is being created and filled. Does that
Yep.
assist you?
Yeah, I think so. So what I'm looking for, and I think would be helpful, is if we get that funding language standardized, that it does, sort of meet, the requirements, you as legislators understand where are we going to have the most effect? What's the language without too much binding? And yet with the sense that if the commission at the June meeting accepts this slate, that we in general as a commission are reminding the legislators that this is important from what we found after 2 years of work, plus that we think that dedicated or continued funding should be made available, right? That.
And I think just to add to this and really appreciate the comments from the senator and delegate that, this recommendation is based upon an identified gap, right? So even if there is funding currently going towards local health departments at this point in time, for example, core funding or through local funding, that funding is not addressing the gap in place and often is stated as being, local health departments and the state health department are underfunded despite the funding that they do have. So it may be worthwhile to, if you don't think it's redundant or too explicit, it might be worthwhile to say new funding because the funding that has been there, or to say dedicated funding because the funding that has been there has not been adequately addressing the gap that we've identified. Any Delegate Bagnall, I see your hand up. I don't know if that's the same one or.
If I may just add to that, because I think part of getting to the nuts and bolts of this is trying to make sure that funding is actually flowing into the local health departments. I think that's what I'm hearing. Because obviously the Department of Health has a certain allocation, but it sounds like we want to somehow articulate that there needs to be funding that then flows into the local health departments through the Department of Health. Is that accurate?
Yeah,
Yes.
I think so. Yes, thank you.
So maybe articulating that a little bit, that it's new funding or dedicated funding to be allocated by the Department of Health to local health departments in assistance of these various recommendations.
And states.
So perhaps we could say new funding should be made available for state and local public health agencies.
It says
because-
especially Maryland Department of Health and local health.
Right. So hopefully that addresses that concern. So using the word new, I don't know if we're track. what we're saying.
Where is this language exactly? Sorry, this is Chris.
Can you clarify, Chris, what language you're talking about? The recommendations on the screen?
Yeah, the funding, the recommendation on the screen doesn't say. Okay, I see. This is the plain language public health information.
Right,
Funding should be made available.
right.
Okay.
To the state health department and local health departments in ensuring that health information is presented in plain language, I think is the crux of what this recommendation suggested.
Okay. I worry that there's going to be a little bit of fatigue if all we're doing is just asking for money for more stuff without stack ranking, without prioritizing and saying here's what we could cut. I mean, the reality of the budget situation in the state is it's not an improving situation even after tax increases. And so I mean, like, if you're just realistic, it's not a compelling. Where does this line up relative to the other ask for money for,
So a couple thoughts. One is that this report isn't just for the current budget climate, right? I mean, this report is what we feel is needed to get us those public health capabilities in Maryland. And if what is needed costs dollars, we need to be able to articulate that need in this final report. And the legislature or others, whoever acts on these recommendations, may or may not take up the recommendation or may not take up, suggest the funding needed for the recommendation, given the, whatever is the current budget climate during that session. But the idea being, 5 years from now, the budget climate might be quite different. And 5 years from now, this report continues on as a report that was data-driven and based on an assessment of the needs and recommendations of a variety of experts as to what Maryland needs in order to fulfill its ideal public health capabilities. So I feel like even if the current budget climate isn't amenable to a variety of initiatives that may have funding tasked to it, it's still important for the commission to articulate what is needed to fulfill Maryland's public health capabilities. The second part, though, of your question or your comment, which I think is really important, is this prioritization process. So that's what we'll be doing in June, at the June meeting and afterwards, based on public comments, is once we get the full slate of recommendations that we've reviewed from the different work groups, we can look at them in their totality and move through a level of prioritization so we can translate that in the final report as to these are some critical priorities, these might be the next level priority, that type of work. And of course, we'll continue that work after the public comment period as well. I don't know if that addresses the concern you raised on priority. Okay, great, thank you.
The other comment to sort of dovetail onto what Chris's concern is, we have to be set up as a commission ultimately. One is that we be very straightforward in terms of what we think are the needs that are out there, right? And what the working groups have come up at saying, here are the recommendations based upon data, based upon, the various flow of information that have been received by these working groups and therefore reviewed by us. Let's be honest, almost every need will come with two suppositions, right? One supposition is you'll do it with current funding, which I know will cause Nilesh and many local health department people angst and will not be realistic. Yeah. We can drop the idea of talking about funding at all, but I think that doesn't really attack the matter, right? And whether it's listed, my fear is a little bit what Chris brought up is, and ultimately we'll see this in the June slate, is we'll have a bunch of recommendations and everyone will have the standard line talking about funding. We may have to sort of reassess that and put in an asterisk saying, okay, as opposed to repeating each and every time, these are the ones that we know for a fact, based upon our data, and the data has come in, that will need additional funding, and label it as such. There's different ways. I'm not sure, again, how this commission in our time period is really honestly going to be able to prioritize A versus B versus C. That's going to be a difficult undertaking. I think what we need to do is say, these are priorities that are out there, and here are the ones asterisk or embedded in the recommendation, depending on how repetitive we will be or accepting to be, that these are the ones we need to find funding paths for. Right, to achieve them.
Okay, great, thank you. Dr. Rochester, and then Delegate Bagnall.
Hi, in reference or to kind of based on the conversation that we've had thus far, I'm wondering two things. One is, do we want to, is it redundant to say both new and dedicated? That's my first question or suggestion. And then going back to, I think what Delegate Bagnall said a few minutes ago, I wonder if we really should be very explicit about this funding going directly to local health departments, because right now we're asking for money and it's kind of general, like public agencies, especially the Maryland Department of Health and the local health departments. Do we want to just request that this funding be used for local health departments?
Okay, thank you. Delegate Bagnall?
Thank you. And I think this is actually sort of circling back to what Dr. Rochester just said. I think where that funding, how that funding is going to flow is going to be dependent on the recommendation, right? So we know that we're building upon our existing system. And something like a plain language public health information, that may be something where the Department of Health is already doing some of that. And we might be able to look to them to fulfill the needs of the local health departments, in which case the funding would be to the Department of Health so that they can provide the plain language information to the local health department. So I think that we might not quite be at the place where we can be that explicit. That might be something to think about between now and June, how we want those dollars to flow based on the individual recommendations, because there will also be a fiscal analysis of the overarching recommendations and the prioritization. So I think just being a little clear on whether it's new funding or whether it's dedicated funding or existing funding. I think Boris had a great suggestion to say, like, these are the places where we know we're going to need new funding, because we've identified a very clear gap. And also looking at, based on the recommendation, is this something where the health department, the Maryland Health Department, is taking point, and the resources flowing into the local health department, or is this a place where the local health departments need that financial underpinning to make good on the recommendation?
Thank you. Okay, any further comments on this recommendation? There seems to be consensus in putting in the word new funding in front of the word funding. I don't know, Michelle, if you can easily do that. I know you're in present mode, so maybe not. And that we just need to clarify the Maryland Department of Health, local health department piece of things and the flow of funding, perhaps by the time that we review this at the June meeting. Would everybody be comfortable voting on this recommendation with the poll and you know, with the understanding that we're going to put the word new in front of the word funding in it, and clarify that this is really intended to support the state and local health departments by a mechanism that will likely come through the state health department. So if we're okay with that, we'll make those revisions to the language of the recommendation. And everybody should have received an email. All the commissioners have an email with a sign in to the poll. And once you're signed in, you'll be able to vote on each of the recommendations that we have. So let's, if everybody's all right, we'll move over to a vote.
Oh, wait, are we discussing, sorry, which one are we, which one are we voting on, or are we voting on all of them?
No, just this one. We're doing one by one now. Because we
Not the one in front of us on the screen, the one about EIOs.
The one on the screen should be the plain language public health information recommendation.
So I do have so I just want to add that this should, we can't just say plain language. It should be ADA compliant language, because there's hearing, visual, and speech disabilities that we need to take into consideration. So it should be plain ADA compliant language. I don't know if Maryland law already says that, but
I believe there's a separate requirement on that. I think if we have the work group co-chairs, any of them online for this recommendation, I'm not sure if that they could speak to that comment.
Sure. And I think Sylvette is here as well. Tony Gedden, one of the co-chairs for this group. And yet this is specific to, and I cannot remember the bill number specifically, the plain language bill that was put into place a few years ago, requiring local health departments and the state health department to use plain language. But that particular, thank you, Dr. Rochester, that particular legislation didn't come with funding. So this is to add funding to make sure that we are able to adequately introduce plain language. And it is separate from ADA compliant language. So plain language is defined in that legislation. It has a very specific definition on what that looks like. And Dr. Cynthia Bauer, who is the executive director for the Horowitz Center, helped us quite a bit in making sure that this was appropriate and aligned with the work that that center is doing. So I hope that helps a little bit in why it just says plain language and doesn't address ADA and other types of language access needs.
That makes a lot of sense. Thanks, Tony.
You're welcome.
Great. Let's move to the poll. And if you could please take your vote for the, and again, you're voting to either advance to the June slate, which is where we do the totality of the recommendations moved to public hearing, to either send it back to the work group for further work, or to abstain or deny the recommendation.
Quick question for Shane. I don't see a way to put my put my name, and when I click on the link, it just takes me right into VBox. But I guess it automatically defaults to anonymous. So if somebody could assist with that, that would be great.
Thanks for bringing that up.
Sure. And thank you. I can do it now. Thanks.
Thank you.
Okay. It seems like that vote has carried, and so we'll move it to the June slate. All right, thank you, everyone. All right, I think we had a lot of discussion that was more general and applies to a variety of the recommendations, so hopefully we'll be able to move a little bit more quickly through the discussion periods for the remaining recommendations. Let's move to the next recommendation, please, Michelle. Thank you. All right, this is about language access for public health information programs and services. This was all read to you already, and you have the supporting rationale in the documents that were sent ahead of time to the commissioners. Based on the prior discussion that we've had, it sounds like we would insert the word new in front of the word funding. Again, clarify that this is to support the state and local health departments, or emphasize that in this further if necessary. Is there any other discussion on this particular recommendation? Anybody in the room, commissioners in the room? Okay. How about any commissioners online? If you wouldn't mind raising your hand or speaking up so we know that you have a comment.
Mara has a comment.
Okay, Dr. Rawson?
Yeah, I guess I'm struggling with, why do we need fund? This is currently a requirement now. I get it. We can make an argument that we don't have enough money to do everything we need to do. But why do we need new funding to, like, for example, to hire bilingual staff? We hire bilingual staff. We make that decision. So I don't know why that doesn't require more money to hire someone who's bilingual versus only speaks one language.
I'll turn it over to the work group co-chairs to speak, but just if I could add to that, I have a slightly different perspective on that. I would say that it would be really helpful to have dedicated funding to be able to hire bilingual staff, because oftentimes, since it's not something that it's something that would really, it really makes a difference and an impact on our ability to meet our community needs. But oftentimes the only thing we're able to scrabble together is funding to support the language line access, which is subpar and far from ideal. So I have a slightly different perspective on that. But anybody else who'd like to make a comment, or if the work group co-chairs wanted to respond to Dr. Rosman's comment?
Mina, I think I just like to support what you were saying. I think in our work that we were doing, we did see that there were inequities across counties, and there were some county health departments that were able to afford having that service while others were not, and they had to rely on the language line, which was not always as effective. And so we put that into one of our recommendations, that at least funding could be given in the places where it was needed, so that as much as possible, every Marylander could have the health services that they need.
The other thing that I would add to that is depending on, and it may depend on whether your employees are county or state, there can be a pay differential for bilingual folks, especially when you have identified it as a requirement for the job. So for instance, we have a really hard time hiring bilingual therapists. The pay rate for those positions is higher than that of folks who may only be English speaking. And so making up for that differential, and if it's a county employee, each county may have different rules for how people are compensated for speaking multiple languages when it's a requirement of the position, and not, hey, we happen to have someone who speaks more than one language, but when we specifically hired for bilingual staff. And then I think Sylvette definitely touched on, when we had the focus groups, and what we heard from folks is the cost of translation and interpretation can be prohibitive. And especially in how many languages are things being translated into, right? Most folks are definitely doing Spanish, but there was a need in many places to do more than just that, but it was cost prohibitive to do additional languages. So I hope that adds some context to what we're recommending here.
Delegate Bagnall, Grant.
Thank you very much. And I would just say, based on this conversation, we might want to consider adding the word local after bilingual, multilingual staff in local health departments, because it sounds like that's where the focus is, on trying to get those bilingual and multilingual staff into the local health departments.
Thank you. Okay, so we would add the word new in front of funding, and then add local in front of health departments in the last sentence. I think Chris, I thought you had a hand raised, but it wasn't the computer hand, it was your own hand on the camera. So I don't know if that was a real hand.
Sure, yeah. I mean, I just, I hope that in June, we can add some magnitude of cost and benefit to these. So otherwise, we're going to dilute the heck out of the ones that we really think we need to see happen. Like if we're stacking up more interpretation and skills for sort of like more interpreters and more language translation for more languages or whatnot, and we're stacking that up against more prenatal vitamins for pregnant moms, like at some point, if we can't do that, we're just handing it over to the legislature, who has even less expertise than we do to do that. And I won't say it again, but it's like, it seems to be like the most valuable thing we can do.
Thanks, Chris. I see a hand up from Camille and Nilesh, but I'm sorry, I don't know who went first. So
Mike, I'll just pop in and say that my comment's pretty brief. I would actually strike the qualifier of local health departments. The Maryland Department of Health also has been exploring the need for translation services and language access. In addition to what's happening at the local health department level, it's something that the Office of Minority Health has been looking into, and there's a dearth of qualified translators. And so the state also needs to shore up its cadre. So I wouldn't localize this issue.
thank you. Nilesh?
I just want to kind of it's less specific to this, but along the lines of where Chris is talking, I think we have a balance between, we've talked about having disease agnostic or function agnostic funding. And we're going to have to, not today, but somewhere along this pathway, talk about the question of what is core funding to public health, what is condition agnostic funding versus dedicated line item funding. So that is one of the great tensions that we do have in how we fund how we fund all of what we do. So just putting that out there, I don't expect us that doesn't impact on this particular recommendation.
Yeah, no, but a very important point that you're making, that Chris has made, I think, you know, again, the purpose and task for this commission in its topics, right? The work groups are the topics that the legislature determined as being the topics of assessment and recommendation. So under the topic of communications and public engagement, the experts that we have accrued in that work group have based on the assessment and the data identified through that assessment, made this recommendation. And while, you know, we certainly acknowledge and respect that there are multiple public health needs that are unmet, that perhaps may have greater impact if we met that need than a need that we might be considering in one of these recommendations. I think it's still really important that we, you know, credit the process that our work groups and that topic that they've been given to explore, and certainly, you know, consider the recommendations that are coming out of the assessment and through that professional group of experts in the work group. Now, the prioritization, as we've talked about, we can certainly have back and forth discussion on that, and we will have some of that discussion in June, and some of that will emerge in the final report. I just think that it wouldn't do this commission justice if we negate the incredible amount of effort and time and expertise that's gone into gathering information about what the gaps may be in Maryland's system, and the recommendations that have come forth to help address those gaps. Tosin.
Yeah, I just wanted to comment that I think this is one of those recommendations that we just have to determine whether, again, it's new funding or, you know, dedicated funding, because there is a huge gap, you know, in this regard. In fact, there's something called Title VI, I believe. Title VI of Civil Rights Act of 1964 requires physicians and facilities that receive federal funding to ensure interpreter services to their patients. However, those who are not receiving federal funding are not required to provide such services. So because people are not required, you know, to provide it, there isn't that mandate, right? And hence there isn't that much dedication, right? So I think being intentional, you know, about, you know, prioritizing this, especially knowing that, you know, it's going to be a huge, you know, it's going to be a huge benefit to, you know, minority populations, you know, Hispanics and, you know, those that need it. I think it's important. So looking at the data, I think we should just let the data, you know, drive us in this, for this recommendation.
Thank you. So I'm going to suggest that we move to a poll with the following tweaks to the language that we maintain based on the comments that have been voiced and written, that we maintain both the state health department and the local health departments in this recommendation, and that we add in the word new in front of funding as we previously discussed. So if there's no other comments, we'll move to a poll, and Shane has sent out that link. So please go ahead and vote. We'll give another minute for the votes to come in. Thank you, everyone, for taking on that poll.
I don't know. I can't, it's not allowing me to vote. It's Maura. I abstain. If you can take that as a vote. Sorry, I don't know what happened. Allowing me to vote.
Sorry, who was the second person that spoke? I heard Maura. Maybe that was just. All right, so the motion, or sorry, the vote carries to advance this recommendation to the June slate. And we'll move to the next one. Thank you, Michelle. All right, so this next one is about public feedback on public health information programs and services, giving the public an opportunity to provide feedback on those public health programs, services, and information. Any questions or comments on this recommendation before we move to the poll? And if we carry along with what we've been doing and adding the word new in front of funding. Any comments or questions from anybody in the room, commissioners in the room? Okay, how about any comments or questions from commissioners online on this?
Just a comment, Boris here, a comment, again, as we look at the slate and ultimately as we publish this, right, this idea of making sure that we remain consistent in terms of use of the lexicon, right? So sometimes we're talking about state Department of Health and others we're talking about local health departments. This one, stands out of just saying health departments.
Just state and local.
Right. So I just want to make sure that whether we have a glossary or whether we have something, so I ultimately, again, this is a comment for the future, just that we be consistent in terms of what we're talking about. Here, we're denoting both local and state health departments without denoting it, but we need to make sure that that is consistent.
Thank you for clarifying that. Okay. All right, I don't see any hands up for comments, so we're going to move to the poll. And if you could go to the polls, please, and cast your vote on this recommendation. Thank you. Maura, if you're still having trouble using the poll tracker, just let us know.
Yes, I was able to get it. Thank you.
Thank you. Okay. So thank you, everyone, for the votes. It carries to the June slate. We will move to the next recommendation, which is public information officers in local health department. Okay. Any comments or questions from commissioners in the room on this one? Okay. And then how about from commissioners online? Any comments or questions on this particular recommendation from commissioners online? If you could just raise your hand if you want to voice. Nilesh?
Yeah, this sort of dovetails with something that I just said a few minutes ago, but there are PIOs in local health departments, and I've read through this. I don't understand exactly what it says, but this gets back to this whole issue of there's also a level of autonomy at local health departments and at the state health department as to how much or little they want to invest in different operational resources. And so I think we should be clear that what we're talking about here is, are we looking for more? There are variations in terms of what's needed in terms of PI support. Sometimes it's a half FTE, sometimes it's 2 FTEs. So I just always worry about putting some sort of there must be 1 FTE kind of thing when it varies. It varies as to what's needed.
If Tony or Sylvette want to respond to that comment, are there any other hands up? Okay.
Yeah, we can speak to what we heard from the groups, from the focus group specifically, and that again is selective based on who decided to participate, right, in those groups. But for those groups who had identified themselves as being, there's a health department with a part-time FTE, or like, hey, I'm a health planner and I'm the PIO, the desire to say we actually have more communications needs than we can address, and there's not typically enough funding. I hear what you're saying, like maybe there's not in certain health departments, and it could vary, but that's what we were told from the assessment findings. And so this is really based off of the assessment findings more than probably asking each and every local health department whether or not they feel like they need a full-time. This was what came forth from that.
And from my recollection on this and from the assessment was that, it may be that there is a PIO contact person at each local health department, but that person often has, 5 other roles. So they're really not a dedicated PIO. It's kind of an add-on responsibility to, other responsibilities they might have, such as deputy health officer or whatever it might be. So I think
that is a decision that is made at the local level. I mean, I guess this is where I'm trying to get a little clarity, right? Like, I understand that's true. That's absolutely true. There may not be, but those are local decisions that are being made.
But are those decisions being made based on funding limitations?
Oh, I'd love more funding, Nicole. I assure you, or whoever said that. I will take more funding.
That was me.
Any day of the week.
I know, Nilesh.
I mean, but what I'm trying to get at here, right, is this question of, and maybe, like I said, maybe this is not the right landscape. Maybe it's after we do these recommendations. And, I'll say it this one time, and I'll move on. But this balance between being very specific about what we want versus having more flexible but greater public health funding. I've said my piece.
Yeah, I hear you. The only other thing I would add to that from our discussions is when we were proposing other things for folks to do, like, hey, what if you had additional tools? What if you had, they said, we don't have the staff or the manpower to make a lot of those things work, was the feedback that we would get when we were having the conversations in the work group. Sure, it would be great, but who's going to do it? Became the follow-up question very often, and it led us back to having at least one position. So I hear what you're saying. That was kind of the feedback that we got in the work group, separate from the assessment findings.
Okay, if no other hands up, we're going to move to the poll on this one. If you haven't already, if you could cast your vote, please, commissioners. Right, so the majority have advanced it to the June slate. All right, thank you, and we'll move to the next CPE recommendation. Okay. Next one is health communication tools modernization. And again, further information on this recommendation, the commissioners, it's on your the materials that were submitted to you ahead of time. Any comments or questions from commissioners in the room? How about comments or questions from commissioners online? If you could raise your computer hand so we know.
more.
Okay.
I have
any more on
I have a
that?
question. This seems very vague to me. Maybe that's the point of it. And I don't know if it's if there's an opportunity to, it says further investigation and research may be needed to determine that. So is the funding for to include further investigation or ongoing investigation?
Or maybe the
it-
recommendation is the further investigation and research.
This is not
I don't know if Sarah can jump in here a little bit. When we looked at this, we talked about the fact that there are tools that aren't necessarily readily available to folks, usually related to funding. But within our work group, there really is not the level of expertise when we'd be talking about what sort of communication tools are out there, what are the platforms. So making a recommendation for a platform or the type of funding or even understanding what different folks already have access to is not something that we knew. And so when we were talking to Sarah, she said there was a separate category that commissioners were talking about if something needed additional information. Yeah. And so that's where we put this one because it really came up kind of time and time again. If we had more Canva accounts, if we had X, Y, and Z, but we couldn't recommend a platform or something that we thought people should have. And so that you were, sorry if I cut you off.
No, I was just saying, I'm in total agreement with what Tony's saying. I said that's the third category, I believe, that can be voted, right? So the thought was that it would go into that category for the most part for a task group or something like that to be formed later on to actually further investigate this.
I think Maura was next and then Delegate Bagnall.
Yeah, it was similar to Matt. Thank you.
Delegate Bagnall.
Thank you. And I think just following on, I'm not sure that we should be leading with funding because it sounds like this is more about professional development of what tools are available. So I think we might be putting the cart before the horse a little bit on funding for the communication capacity when it really sounds like it's more like a task force to identify modernization tools and professional development opportunities and training.
Thank you, Delegate. So maybe some opportunity for the work group to refine the language a bit more. All right, any other comments online? Okay, all right, let's move to a poll on this one. Okay. It appears that we're landing on recommitting this recommendation to the work group for further refinement based on the conversation we've had here. Although Delegate Bagnall, I don't know if that hand was from before. If that's a new hand, feel free to talk.
It's a new hand. Just as we were having the discussion, I know the work group had spoken to the fact that they didn't necessarily have the information in the work group. Is this something where they were looking to move it forward so that the full committee or the full commission could weigh in on those tools, or did they want to reconsider the language of how to move this forward?
If Tony or Sabat want to respond.
So we knew we didn't have the expertise on what kind of tools were needed. So our major suggestion was that there was a task force that can actually further investigate this. So we could definitely reword it to reflect that, but that was what the further investigation and research maybe needed to determine modernization needs was for.
Got it. Okay, thank you very much.
You're welcome.
So it's been recommitted to the work group, so if the work group could, if they feel they want to re-advance it to the commission, then perhaps they could relook at the language here and change it accordingly to.
I just want to get clarification. Is the question on what type of modernization tools?
I think it was I believe, if I remember correctly, the question is, if the recommendation really from the work group is that further study is needed to help identify those tools, to help identify what's needed, then perhaps the recommendation could be more of a task force or a study on the matter versus the funding to do something that we haven't quite clarified yet.
Makes sense. Thanks.
Okay, great. All right, we'll move to the next health communications one. And then after the health communications group, everyone will take a short break and touch on the other work groups. Okay, we have two more on health communications. Okay, so the next one is the community health needs assessment support. Any comments from commissioners in the room? And again, we'll add the word new in front of the word funding. And again, also acknowledging the comments that have been made about prioritization and the comments about categorical funding versus, general funding. Any comments or questions from commissioners online? If you could put your hand up if you have anything you want to say before the vote. Nilesh, thank you.
Yeah, just seeking a little clarity between the submission name, the recommendation language, what we're going for here. It's very China specific. And I'm trying to get a little bit more understanding of the China only happens so often. There's carry through work. Like, what are we trying to go for here?
Yes. So just to provide some more assessment data, most cases of the community health needs assessments completion occurred through collaboration between local departments and hospitals based on the assessment finding at 63%, whereas you have 13% of local departments and hospitals each completing their own individual community health needs assessment. This has led to duplication among local departments and not allowing for prioritization, right, in terms of their programs for the community. So whereas NACHO highlights also this gap and acknowledges the under-resourced, right, issue leading to these efforts. And NACHO also recommends that the gold standard will be to foster collaborations between local departments and hospitals so that they can complete this community health needs assessment together. So our goal is 100%. We're at 63 for the collaborative efforts among LHDs and hospitals, and you still have pockets of LHDs doing their own community health needs assessment independently. I think this recommendation would promote coordination and would reduce duplication efforts, would help align priorities and improve implementation of community health strategies. Thanks.
Any other comments from commissioners online or in the room? Or if the co-chairs of the work group would like to respond, say again. Dr. Levy has a question. Okay, Matt.
Kind of a little fun. I lean towards what Nilesh said. I think I understand dedicating it, but it's dedicating somewhat to this, but it seems very specific, and it might be a way to flip this around to say, hiring a community coordinator or someone to help with community health strategies including the health needs assessment. And that way they can do other things if you're going to hire them full time, happens every 3 years. So instead of having it just the community health needs assessment, you have it community health strategies, including the health needs assessment and the community health improvement plan and whatever else you want to do, but you include it in the language, but don't make it specific to that particular activity. That would be my thought.
So Matt, just to summarize what you mentioned, and again, to echo what Alicia was mentioning too, or at least what I heard, that there is a process, a continuous process of community health strategizing and improvement that involves the community health needs assessment, but is not limited to the community health needs assessment. And that it might be operationally easier to implement funding if it's for that continuous process, not just the point in time that might happen every 3 years or 5 years or however often the CHNA happens in a particular county.
Yeah, that would be my thought.
Thank you.
You said it more eloquently than I did.
I just summarized. Any other comments? Okay, we're gonna move to a poll to either advance or recommit to the work group or abstain or say nay. So the recommendation will be advanced to the June slate with the word new, as we talked about. Okay. We'll go to the last one for the communications work group. Thank you, everyone. I know this has been a large number. Youth education. I'll take comments or questions from the group in the room, the commissioners in the room. I would like to offer a comment that I feel instead of saying pediatricians, it should say pediatric healthcare providers, so that it's more inclusive of other clinicians who take care of children, including family doctors and nurse practitioners.
If I could just say something, I love that wording that you suggested. And so I think that would be more than fine. I think that the work group would be more than fine with that also.
Okay, no comments so far. Matt, online, and any other commissioners, if you could raise your hand. Go ahead, Matt.
I just had a question. I like this, but I do think that pediatric providers, I think this is great. I think it should be educators and all that stuff. And I think it's just good. I'm just curious, why is there one that you developed for adult health literacy that isn't in the packet yet? Because I think we have a big issue with people understanding, as adults understanding. This takes care of it in a generation, but it doesn't necessarily take care of the folks now that are adults that don't understand health.
I think the quickest way to sum it up, Matt, is probably all of the other recommendations are mostly targeted at adults, right? The way that we are communicating now, most of our communication efforts go directly towards adults, and they're not necessarily a captive audience, right? They're folks that we have to seek out and find different ways to communicate with adults, whereas this would allow us the opportunity to really standardize some level of communication with a group of folks really early on in different age groups in a way that we really can't replicate something quite like this with adults, right? For adults, it's optional. If we get the school systems to agree with doing something like this, health education already exists in public school curriculum. So is there a way to capitalize on that? And I don't think the work group had a specific, here's what we do to improve health literacy for adults. We talk more about plain language access to, and how are we communicating with people in a way that they want to receive it, more so than improving the health literacy overall, because that became that's a big question. And I don't know that we came up with a recommendation, or that there's one in the back somewhere that we're going to drag out. I think this is probably it for us.
Thanks, Jen. Okay. Any other comments or questions from commissioners online? All right, seeing no hands, and if I'm missing your hand, speak up, please. We'll move to the poll. With the, again, with the modification, we'll change pediatricians to pediatric healthcare providers. Okay, the majority has voted to advance this to the June slate, and we will advance to a 8-minute break. So we'll reconvene at 3:45. Thank you for the patience with this process, and we'll appreciate that. And thank you to Tony and Savat for being on and explaining in response to some of the questions. Thank you. All right, welcome back, everyone. Thank you so much for your patience. And we're going to proceed. We had a little bit of just in reflection on our attempt to do consent agenda. It may be that we continue doing the individual approach if commissioners feel more comfortable and have an opportunity then to digest better if we do this individual approach. So if okay with you, what we'll do is we'll just review all the recommendations in the beginning that seem to help the group recognize what was on deck for the work group, and then just go through each recommendation individually and move for quick votes if there's really not any comments or questions. Okay, so we'll start with the data and information technology work group, and I'll pass it over to Shane, and he's going to review all the recommendations for us.
Great. The first data and IT workgroup recommendation is DIT 032, centralized data repository. The recommendation is to augment CRISP to ensure that it is a centralized statewide data repository to receive structured data from multiple secure and approved sources, including from healthcare, public health departments, and social services providers. The repository should be able to organize, cultivate, link, and release data sets for multiple stakeholders to engage in research and quality improvement, analytics, resource management, and public access to de-identified data.
Okay.
The next slide, or the next recommendation is DIT 033. Uniform data standards. The recommendation is to create and implement a uniform interoperability data standard for definitions and data sharing across health, social services, and public health systems, and ensure a uniform master person index across data sets and unique systems and streamlined workflows for end users. DIT 034 hub and spoke analytic model. The recommendation is to create a hub at the state level and spokes at the local health department levels through a model of analytic functions to create consistency in outputs and efficiency in administration. To also create a streamlined process for data use requests, including a central community portal to include both data collection function as well as dashboard and tools for community engagement and education. DIT 035, one state electronic health record system. The recommendation is to determine and purchase a universal electronic health record platform for the Maryland Department of Health and all local health departments that can integrate the 5 core foundational public health areas if possible. Leverage purchasing power to reduce cost and improve efficiencies of management and maintenance. If additional systems are required, ensure the minimum number of universal systems needed to achieve comprehensive public health data capture. The last from the work group is DIT 036, data use efficiency. The recommendation is to streamline the processes of data use, including agreements across state and local government agencies and non-government entities to maximize access to appropriate data for use in tracking, research, and funding to demonstrate savings or return on investment across agencies.
Thank you, Shane. So those are the recommendations from the DIT work group. And I know Pat Levy's on as a co-chair of that work group, and I'm not sure, I can't see if Craig's on as well, but he's the co-chair of that work group if he is. Talk as well. So we have our first one, the centralized data repository. Are there any comments or questions on this from commissioners in the room? How about comments or questions from commissioners online? If you could please raise your computer hand. Okay, all right, so seeing none, we'll move to the poll. So if you could see your poll again. Commissioners, Okay, the majority has advanced this recommendation to the June slate. Thank you, commissioners. We'll move to the next recommendation. The next recommendation is for uniform data standards, and you can read that there. Comments or questions from commissioners in the room? Did we skip one? This is the next one. Okay. Comments or questions from commissioners online, if you could please raise your computer hand. Okay, we'll move to a poll. So if you could please cast your vote in the poll. Okay, this will also advance to the June slate. Thank you, commissioners. We'll move to the next recommendation. Can you move us to the, oh, this is the hub and spoke. Sorry, we're already there. My bad. All right. So comments or questions from commissioners in the room on this recommendation called the hub and spoke analytic model. I have a question on this, and that is really to just get some clarity. Perhaps Matt, you could explain, or Craig, if he's on. Is this to centralize data use requests so that data use requests that are intended for a particular local health department actually go to the state first, so that the state handles the data use requests? Or am I not understanding?
It's like half correct. There's a centralized analytical function because we'll have one EMR system, one data repository, but it's not all a state function. It's a local state function. So you have a representative that, not a representative, an individual at the local health department that is able to function and pull data and run reports and do an analytics on the data repository. But because it's one system, they have a more efficient way of getting the data, and they're also certified, if you will, to be inside of the system. So it just creates a lot of efficiencies and improves your ability to get work done faster and to get those outputs that you need for your local health department.
Okay, that helps. Thank you so much for clarifying all that. Any commissioners online who have questions or comments? Nilesh, thank you.
Yeah, just maybe just a name change, but it seems more like we're talking about dashboards and data sharing more than hub and spoke analytics. These dashboards are referenced throughout this. So I'm just trying to understand what the hub and spoke analytics means if it doesn't mean dashboards and data sharing.
So say you want to assess the number of smokers in public housing in your community. That's not going to be on a dashboard necessarily, but that might be a function. You have to maybe either write a report, or you might have to go into the system and pull that data down yourself. So there are dashboards for sort of general consumption, but there might also be specific reports that you want to look at from a particular angle for your health department, and your local spokesperson will be able to do that most efficiently because they're embedded in your local health department, but they have access and clearance to be able to go into a system that they can pull. They know how to use that system. So it's not an either or, it's an and. There'll be community facing dashboards and tools, and pulling that all together into one location. Right now, the state has several different dashboards, and they're wonderful, but they're in different locations instead of in a place that people can go and say, oh, these are all here, and then also these are here. These are the tools I can use to understand my community. That answer your question?
Sort of. Sort of. I'm just trying to understand the little, like, I guess there's two pieces, right? There's one is centralizing the access to that data, right? And pulling down what's on that dashboard. But then there's questions, queries that are bespoke or ad hoc that are not contained within that. And that's a different beast, right? Like there's two ways to deal with that. One is ad hoc requests. And the second, which is far more, I guess, advanced, which, things like data warehouses or data lakes where you're tossing a whole rack of data in, and then there's all sorts of agreements and stuff. That's a huge undertaking. I'm not sure that that's what we're talking about here. It would be really cool, but considering the range of things we need to do, I'm not sure we're there yet. But I'm just trying to make sure that we're pinning down what we want here.
Mm-hmm.
Just to offer a little bit of background. So CRISP has distributed, like the actual, you don't necessarily need a data lake, or they have one, but you can leave the data distributed in its existing source systems by integrating them together and then using the existing sort of master patient, sort of this probabilistic matching technology to say Jonathan Smith is the same as John Smith in this different system, allows you to do this reporting work through the existing CRISP system. So it's not stand up some big new framework. It's mostly there. It's about sort of integrating the social services and other public health data with the clinical data and the technology stack that already exists, and then enabling the public health workers within each local health department to use it and train them to use it. I think.
Yeah, that's basically it. And so you're right. There are sort of two parts to this, and we thought about whether we wanted to sort of pull them apart, the community portal piece with the community engagement education, and the analytics piece, which is more of a function of embedded in the health departments that are seamlessly tied to the central folks, and how they do pull reports. But additionally, one of your community partners could come to you and ask you to help them run a report on something, and that is another function that they would do. So we put the community stuff together and the analytics, because they're hopefully the same person's doing kind of both function at the local level. They're not necessarily building dashboards, but that they're using and analyzing the data in the repository, if you will.
Thank you for those comments. Are there any other comments or questions from the commissioners online or in the room? If none, we'll move to poll. I think the majority have advanced the recommendation to the June slate. Okay, we'll go to the next recommendation, which is the one state electronic health record system. And I'll move to questions or comments from the commissioners in the room. I have a question, and that is, did the work group intend for this universal EHR platform to be mandatory use by all the local health departments, or as an option for the local health department to use?
The intent was that this would be it, that this would be the system that everybody uses, so that it's it's easier to maintain. It reduces cost. It improves interoperability because there isn't any need for that to have that transmission. It's all one system. So it is a mandatory. Mandatory might not be the right word. You could either opt to. I suppose you could opt out, but the idea was that there was one system for all the LHDs to do. It just creates so many efficiencies and hopefully lowers cost that it made sense.
Thank you for clarifying. Any other commissioners in the room? Okay, I see no issue online, and if any other commissioners online want to speak, if you could raise your computer hand as well.
So this is one where I do want to get some clarity because I think there's two issues here. One is having a single electronic health record system, and the second is having mandatory data interoperability standards so that whatever system you pick, we have data interoperability like some of the other recs that came before, so that data can be uploaded and downloaded, right? I think very much like what you see in the healthcare space where you have different EHRs, right? You've got Athena, you've got Epic, you've got Cerner, but there's an interoperability that allows them to exchange data with CRISPs, upload, download data. I actually don't care whether there's one EHR system or not. I care that there's data interoperability and sharing between counties and between the state. But I will note that in conversations that we've had with LHDs, there's been resistance to the idea of having one electronic health record system that is mandatory. And if it's not mandatory, then we're back to the question of, is there, like, how are we requiring data interoperability so that data can be exchanged, which is really the core question, right? So I just want to clarify what we're going for here, because there are two different goals that can be accomplished, and this one seems to put them both together.
They're not together. This is specifically for Maryland Department of Health and the LHDs, so that we can build. There are no electronic health records that I'm aware of, and nobody in the committee was aware of, that are specifically for public health and the 5 core foundations of public health. And that's why I said, if possible. But if you have enough leverage because of your ability to purchase a large system, you're also going to be more likely to be able to get what you want, which is additional builds to address public health. So I believe any health, any electronic medical record company that successfully taps into the public health market is gonna do well. The interoperability question is different because the interoperability is also function of the other health systems that are not the public health system. So all the hospital systems, all the social service systems. So this is not for all of them. Excuse me. So we're not asking MedStar to change their EHR system to the one that we're on. Their interoperability is built already to CRISP, because that's going to be the central repository. So we can transmit information, or if we have one universal system and say somebody, it'll be easier for MedStar to build one interoperability system to the multiple public health departments that they work with, instead of having them have to build multiple systems from their side. So it simplifies the whole process. It streamlines the whole process. Does that make sense? So we have a recommendation around interoperability.
I get it. It's not that I don't understand the issue. I just think that there's two different things happening here, and I just want to make sure that we're clear that you can do data interoperability requirements without one EHR, and just noting the historical resistance to having one EHR. So I'm fine with it.
Yeah,
The majority of people that we spoke with were for one system. So, but there were some that had some questions, about vulnerabilities and things like that. So
the intention here, Nilesh, is to get to scale so that you can get more functionality in the EHR.
Oh, I get it. I get it all.
Any other comments or questions from the commissioners online? You could raise your computer hand so we know. Okay, all right, we'll move to a poll on this one. Thank you. All right, this will advance to the June slate. We'll move to the next recommendation, please. The next is data use efficiency. And if there are any comments or questions from commissioners in the room. Okay, any comments or questions from commissioners online?
Quick question, and it may be, I'm trying to scroll through the body. Are we making recommendations as to how this is done, or we're basically just saying that we think that this should be done, the streamlining process?
the recommendation is not how it's being done. That'll have to be determined. But the recommendation is that it is done.
Okay, thank you.
Any other comments or questions from commissioners online? Okay, all right, we'll move to a poll on this one. Okay, this too will advance to the June slate, and we'll move to the next recommendation, which is going to be from the funding work group. And so, sure, or that's fine. If it's already queued up, that's fine. We have time. We're good. 15 minutes. All right, so let's move to the funding work group, and then Shane's going to read out the recommendations from the funding work group, and Larry Polsky is here in the room. I'm not sure if Gina's joining us online. Okay, Gina's online. So our two co-chairs are with us from the funding work group as well, in case there are any questions or discussion needed. Okay.
The first is FND 021, funding from charitable foundations. The recommendation is that the Maryland Department of Health and local health departments should coordinate with the governor's office to align public health initiatives with the goals of charitable foundations to bring more grant money into Maryland public health agencies. Next recommendation is FND 022, Maryland Department of Health Grant Team. The Maryland Department of Health should expand its staffing to search for grant opportunities for both state and local levels. The grant team should include representatives from small and large local health departments. Next is FND 024, community benefit spending. The recommendation states a percentage of community benefit dollars shall be transferred from acute care nonprofit hospitals to their respective local health departments, and to a lesser degree, the Maryland Department of Health. Funds equal to 5% of each hospital's 2024 community benefit spending would be transferred to public health agencies during the first year of this process. 90% of the total funds will be retained each hospital's local health departments, and 10% to Maryland Department of Health for statewide coordination of certain programs. Based on current hospital IRS 990 form reporting, this amounts to approximately 0.5% of a hospital's total budget. The percentage of community benefit funds transferred to public health agencies would increase annually by an additional 5% until a total of 30 to 35% of each hospital's community benefit annual funds are administered directly by local health departments and Maryland Department of Health. The next submission is FND 025, Medicaid rebates to public health agencies. The language reads, Maryland Medicaid should develop a program to share in cost savings with public health agencies that produce measurable reductions in Medicaid expenditures as a direct result of successful programs. Public health agencies shall be rebated 25 to 50% of cost savings realized by Medicaid as a direct result of program outcomes, minus the sum of any public money that funded the public health program. The use of rebated funds should be unrestricted to allow public health agencies to optimally match funding to local needs and undertake innovative projects.
Thank you. So we'll go through one by one on these, starting with the first. Are there any questions or comments from commissioners in the room? Okay, how about questions or comments from commissioners online? If you could raise your computer hand. Nilesh?
Just a thought about why this is limited to working with the governor's office. This is something locals can do, state can do, right? There are multiple avenues, including local charitable organizations. I would just make this broader.
Did any of our co-chairs want to respond to that?
Yeah, so no one wouldn't argue with that. The reason that we decided to put the governor's office particularly in this is we have a governor right now who has a background of heading a charitable organization. And we've heard some comments from the governor's office about work within that sphere out of. So it seemed like with the current administration, that might be a way to bring charitable foundations to the table a little bit more quickly, would be to coordinate with the governor's office.
That's already happening at the governor's office level, so I can tell you that. But I think the broader point was more just there are different avenues here, and we should note that there are local avenues as well.
We'd be happy with wording changes, like including coordination with the governor's office. So that would be one, it would be clear that would be one avenue. If the commission felt that striking that completely, again,
Or just say with the governor's office and other entities
that would be
to align public health initiatives with the goals of charitable foundations. And you could even say it further, just to speak to Nilesh's point of saying and other state and local entities. Okay. So with that modification, where we say should coordinate with the governor's office and state and local entities or other state and local entities. Are there any additional comments or questions from commissioners online? No. Okay, all right, then we'll move to a poll on this particular recommendation. Thank you. You're managing well. Okay, This one's gonna move to, the public, the public comment slate in June. Yeah, thank you, advanced slate. All right, we'll move to the next recommendation, please. Which one?
Right there.
Okay,
22.
so we're on 22 MDH grant team. Any questions or comments from commissioners in the room? Okay, I see Chris online, and then any other commissioners online, if you could please raise your hand, Chris.
I would just combine this one and the last one. I think it's getting at the same thing. One is pursuing private funding, one is pursuing public grant opportunities, but it's the same muscle memory. Like it's pitching projects.
I mean, any other comments people want to offer? Just to respond to that, Chris, I think it may be the same concept, but the at least from my experience at local and then previously at state levels, the finding of grants in the public sector is quite different than the finding of grants in the private sector, in the sense of public sector grants, you know, have a timetable, they're published, they have specific criteria. You might need to look in different federal agencies, for example, or state agencies, depending on what the source might be, to find grants that you're eligible for. Whereas with the private sector, it seems to have been, at least from my experience, a little bit more of a, you know, pitching a concept, being invited to write a full proposal. It's a slightly different process. I think the purpose of this was really to, it seems like, at least based on my reading, to scope out what grants, already formed grants, are available, separate from the concept of pitching to a philanthropy organization a concept so that they invite a full proposal. But I agree with you that a lot of this is about the same thing, is about demonstrating the data, providing the rationale for the impact, describing the problem, all of that. So there may be some good opportunity for overlap. Any other comments from commissioners online or questions? Anything? Okay, we'll move to a poll on this. This one's going to advance to the June slate. We'll move to the next recommendation. This is on community benefit spending. Any comments or questions from the commissioners in the room? Okay. All right, I do see some hands raised on with the online commissioners, so we'll go in the order that we saw them. Heather, Delegate Bagnall, Nicole, and Chris. Anybody else with their hands raised? Can say?
I just, I'm a little concerned about this one because I'm not sure how it interacts with the AHEAD model and the already established pillars in the AHEAD model for those community benefit dollars. So if anyone has more information on how those integrate, I'd be appreciative of that information.
Did any of the co-chairs have a response to that?
What we're trying to achieve with this is a more optimal use of the money that's supposed to be going to community benefits. So it was the feeling among the work group members that the way that the structure is right now, there's an enormous amount of overhead that hospitals have, and that hospitals are really geared toward providing acute clinical care. That moving a portion of this over to local health departments and to a lesser degree MDH would actually further the goals of the AHEAD model by putting that money into organizations that are devoted and really expert in true community health.
Just as a follow-up, would that mean that it would still be grants, but they would be allocated through the local health departments as opposed through the hospitals?
So we don't have attorneys on our work group, and I think that if this moves through the commission as a recommendation, that in all likelihood, the next step is going to be a sit down with, at minimum, MDH, Maryland Hospital Association, local health departments, and then the attorney and accounting experts as to how this money would actually be physically moved. So beyond the expertise of our group, but again, the goal is this money is intended for the benefit of the community for population health, and the vast majority, all except for one member of our work group, voted for this recommendation. And the thought behind it was that the money would be used more effectively. And again, we're not talking about moving all the community benefit dollars. We're talking about a relatively small, only 5% of that each year. So it would be an incremental move, and that ultimately the goals of the HEAD model would actually be furthered by this.
Thank you.
Yeah, just
Senator William had a response as well.
Just 2 points on the head model in relation to this recommendation, just briefly. One, we don't know what the status of the head model is going to be. It could very well be dismantled, and we just don't know. And so I think one point is to, have a recommendation here that's kind of agnostic of the head model. That, you could very well a year from now not have this. And so I think, losing this recommendation because the head model would be doing a little bit of a disservice to community benefit dollars. And, this the requirement for community benefit dollars for hospitals has been around for a while. It preceded the AHEAD model. It will probably post-seed the AHEAD model, whatever comes out of AHEAD or whatever AHEAD transitions to. And so, I think there's a longstanding recognition that these hospitals ought to be providing community benefits. And so I think it's a fair recommendation of separate from AHEAD that, a portion of this should be designated for public health, given that the direction that we've been kind of seeing most hospitals move in our global payment system is to be more community health oriented.
Thank you. And then online we have Nicole, and then Chris, and then Alan. So Nicole?
Hi, yes, I think, I'm certain we all agreed that the current system is suboptimal. I do have concerns about the part of going up to 30 to 35%. In light of everything, I agree with everything that has been said. And we all know that particularly in our state, prior to the HEAD model, there's always been a model with the total cost of care where hospitals are held responsible for the communities that they serve. And there's, attribution models and things of that nature. Again, I'm not saying it's working great, but I guess my question is, what was the rationale behind the increase annually to the 30 to 35% of their funds, community benefit funds?
Well, I think in many cases, you can make an argument that number should go higher. And so it was the thought of the group that we needed to pick a number that would be, we realized that ultimately, if this is going to move forward, this needs to move through the legislature, that it needs to be modest enough that it would be at least somewhat palatable to many different interests. So and again, we're not looking to disrupt. We're not saying take a third of the money right off the bat. We realize that any shift in funding has potential impact. And so again, this very gradual movement also gives a sort of a built-in test of how things are going, that over a 6 to 7 year period, there will be monitoring. And that was also one of the considerations in the debate, is that how hospitals spend this money is essentially cloaked. There really is no detailed methodology out there. The law, as talked about back in December, says that community benefit dollars should be a planned, organized, and measured activity. that is intended to meet identified community health needs. And local health departments do that all the time. We have every grant that we have to account for literally every dollar in a very detailed way. Who we're hiring, not just it's going to staffing, or not just it's going to cancer prevention, which is what you tend to see in the hospital self-reports, but we're going to show, every hour of nursing time, every hour of community health worker time, every blood pressure cuff that we distribute in a community. So this actually sheds a lot of light for both the legislature and for the public as to how this money will be spent.
Thanks, Larry. Okay, we have some additional online comments. I'll go in the order. Chris next, and then Alan.
Yeah, I mean, what you're proposing is, can you hear me? Yeah, what you're proposing is explicitly a provider tax, which is just, it's going to be like the current Congress is going to legislate against it. But also it's like the way, having seen at least at one hospital, how the community benefit dollars are spent, it's paying nurses and physicians. It's basically a plug. So the hospital has to serve all comers, and so they're using provider time to serve people who are otherwise uninsured or underinsured. And I just don't think, I think this approach is you're gonna create a very it's super aggressive. And maybe that's the intention, is to evoke ire, and but they're the much softer approach was the legislation that we supported earlier, which was to use the rate setter to create that population health trust that would allow some flexible use of healthcare delivery dollars to do work upstream. But arguing that we need to take money away from hospitals because they have so much overhead to give it to government is kind of like, doesn't make any sense. And also you're going to create an adversarial relationship with the hospitals, because you're essentially telling them that we're going to tax you to do the work that you should be doing. So I absolutely cannot support this one, because, but I think you're also, I think that the tone of it is, I just want to make sure you guys understand what you're saying is we are going to tax you to do the work that we think you should be doing, but you're not doing it well. And and that might be exactly what you're saying, but it's, it probably should, the language should probably be softened. I would focus around, I would change it to say we're going to mutually agree on how the dollars will be spent or what goals will be achieved, and not just we're going to take your money.
I'll just remind the commission that community benefit dollars are there because hospitals don't get taxed. They don't pay state sales tax. They don't pay any income tax, either at state or federal level. They pay no local property tax. And of course, they get better rates on bonds, and they're allowed to collect charitable donations through their foundations because they're a nonprofit entity. So
government doesn't get taxed either.
The idea that this is a tax on hospitals, the whole point is this money's there because they don't get taxed. And there are plenty of national studies that show when you look at for-profit hospitals, that they put as much money back into their communities as nonprofit health. So it doesn't mean that hospitals can't do this without these tax breaks. But the question is that, or the entire premise of community benefit is that these dollars are supposed to be going back in agnostic to the needs of the hospital. These are supposed to be going back into the community to meet needs that otherwise aren't getting addressed.
Thank you. Alan?
Yep. Thank you. Yeah, I would like to thank my colleagues on the funding work group. I was the dissenting vote that opposed moving this forward today. And I think Chris just made a lot of excellent points. I would just remind again that community benefit is really a number of things that includes charity care, health education, free clinics, preventive care, screenings, vaccination, volunteer hours. All of that is part of the public health system in each of our communities. And just taking an example of fundamentally how this would work as it's currently written and recommended. If a hospital reports having provided $20 million in free healthcare service to uninsured people in the past year, how can we expect them to then provide a shift of up to 30% to a local health department? That's an additional $6 million burden being asked for the hospital to provide. The community benefit is largely a statement of value for services that have been provided. It is not a fund. It's not fungible dollars that can be reallocated. And I really think that we're missing the point on this recommendation. There is, I think, a great opportunity here to really work together to leverage the strengths of public health with hospitals through this process to look at things like how do we identify what the priorities are for our community health needs through the community health needs assessment recommendation that we just advanced, and how can funds be dedicated to meeting those health needs collaboratively. I do think the recommendation is it's divisive as it's written, and I don't think it will really accomplish what's being hoped for here. So I oppose this. At the very least, I think it has to go back to the work group for additional reconsideration.
Thank you, Alan. Okay, if no other comments online, we're going to move to a poll for this. Oh, sorry, go ahead, Senator Lamb, and then we'll move to the poll.
Yeah, I mean, I think the intent, and obviously it wasn't here when they, I guess devised like the purpose of community benefit dollars, but my understanding of the intent is that it should help the community and public health, that it should be leading to greater integration between our health systems and hospitals and public health. And, being able to utilize some of that funding that's in a more coordinated fashion than just health fair here or vaccination clinic there, or we're going to throw together this health education event, that this money will help with better coordination of that. And starting somewhere, I think, is really important, because otherwise a lot of this could simply be gobbled up by indigent care, which my personal opinion is not what I think community benefit dollars were intended to do when they were first devised. And so I don't think, it's too much to ask for some additional coordination. And the best way to coordinate is through some tie-in with funding, whether you want to play with the numbers or not. I think this is a starting point to be able to at least bring together the stakeholders to the same table to help with some coordination from the public health.
Thank you, Senator Lamb. We're going to move to the poll. I'm mindful of time and that we have two work groups still with recommendations to go through. We can have all commissioners please vote. And it looks like so far
Cannot support.
So this is not going to be advanced to the June slate. Okay, we'll move to the next recommendation, please. No, it didn't go back to work. The next recommendation is Medicaid rebates to public health agencies. Any comments or questions from commissioners in the room? Okay, comments or questions from commissioners online? Any hands up? Okay, we'll move to a poll on this. Chris? Oh, sorry, Chris, did you have a question? Oh, I didn't see your hand. My
Yeah,
bad.
is this through changing the? Is this through changing the MC? This is changing the MCO contracts. I think this is a great idea. I mean, is that like how you would do it? Through the MCOs? Who?
Yeah, I mean, the Medicaid, would Larry or Gina like to comment on that?
And we did not have the benefit of attorneys and everyone else who would need to come up with the specifics. So yeah, I can't answer that question. But we know through NDTCP, there's lots of mechanisms to refund when health agencies in the private sector meet benchmarks.
The contracts would be one mechanism. Any other? Okay, then we're going to move to a poll. And majority have advanced to the June slate. Thank you. We'll move to the next one. And the next one is for the GOC work group. So I'll pass it over to Shane. I think there's 2 recommendations here, and then we'll get to the workforce work group. Thank you so much for your patience.
GOC 011, shared governance utilizing a co-creation framework. This is a resubmission from an earlier draft, the April 3rd meeting. The recommendation as resubmitted is that the Maryland Department of Health will develop and implement a framework for co-creation within Maryland's governmental public health system rooted in equity that includes shared leadership, learning, decision-making, system-wide, and mutual accountability.
Just as a correction, just because I'm on this work group, I think it was supposed to be, and perhaps Barbara could correct me if I'm wrong, the Maryland Department of Health and local health departments in the spirit of co-creation, but perhaps I'm.
Yes, thank you, Mina.
Okay. So the correction is that it's supposed to be Maryland Department of Health and local health departments will develop and implement a framework for co-creation. Right. Thank you. And I think decision-making system-wide is one phrase without the comma in between. So, okay, great. Any further questions or comments from commissioners in the room?
Another to read before.
No, I know, but, oh, sorry, we're doing the overview. My bad. I forgot.
The next one is GOC 026, building anchor partnerships with academic institutions. This is a new recommendation that reads, Maryland Department of Health will facilitate the development of memoranda of understanding between Maryland Department of Health and local health departments with academic institutions, outlining roles, responsibilities, and expectations for mutual benefit related to research, data, and workforce support.
Okay, we're going back to the first one. Any further comments? So we made the comment about it's saying Maryland Department of Health and local health departments will develop and implement, et cetera. And that decision-making system-wide is its own phrase without a comma. Any other comments or questions from commissioners in the room? Comments or questions from commissioners online, if you could please raise your computer hand. Nilesh? And
Yeah,
go ahead, Nilesh.
Okay. I think this is starting to get into a place where I think we're blurring what are the roles and responsibilities. And I said this in our governance work group of the Department of Health, the State Department of Health, and the local departments of health, right? I think that there are delegated responsibilities, and this one starts to really touch on what are the roles that we have. Shared governance, I get that. I get that in the abstract, but there's also lots of, I think everybody who's working in either state or local knows this, there's lots of imperatives that come down in terms of funding, in terms of policies and priorities. What is the governance implication of this, right? Who's responsible? Because there are still responsibilities. And so it's one thing to say that we're going to do this. But then it has impacts on who is legally responsible or statutorily responsible for this. And so I'm just going to say that I do not feel comfortable with this one moving forward as is.
Delegate Bagnall?
Thank you very much. And I think my comments sort of echo Dr. Kalyana, but and additionally, you know, I have a question when we're talking about co-creation, the framework for co-creation. Are we building on the existing framework of our public health system, or is this a framework for a new public health system, which I think it actually goes beyond the purview of the commission. So I'm not really clear about where we're trying to get to with this. And it does give me a little bit of pause just because we don't have, from administration to administration, we don't necessarily have the same equity. So understanding those shared responsibilities can be quite different from administration to administration. So I think I would just like a little clarity on what we're trying to get to with this recommendation. Thank you.
If Barbara wanted to speak up in response to any of the comments, feel free.
Well, I think it would be helpful to see the rest of the information that had been provided to provide more of the context for what this is about, because I can see how, you know, listening to what you were saying about, oh, is this about creating some new government? This is really about co-creation in terms of not our structures, but actually in developing, you know, the policies, the programs, ideas that ultimately end up impacting local health departments. This is about having more of an opportunity for it to last throughout and be sustained across different administrations, as you noted. We very much appreciate what Nilesh has done and the current administration. We have had other ones where it hasn't quite been the same, and it's been at times a directive and dictatorial situation, and that there are times where, as I understand the interest in this had come up, that there have been times where lack of engagement of the health officers or local health departments in the early stages of the policy development led to policies that weren't as optimally effective and perhaps were problematic in some ways. And so this is merely expanding what Nilesh and his predecessors have done, where we do meet regularly, and then this is taking it a step further. In the Maryland Department of Health and local health departments, or the health officers sitting down and saying, okay, so what are the areas where where there is an interest on, I'll say both sides, you know, on both sides of having more input in the early development, be at the table for. And there may be, as Nilesh had said, you know, I'm sure that there are areas where it's not up for discussion. It is what it is. And that is to be expected. But I would think that there might be a large area where, yeah, let's welcome the health officers at the table when we're developing policies or programs designed to impact the communities throughout Maryland, since we are a step closer to the communities. So I think that's what was behind that. And if you have the benefit of being able to see the rest of the documentation and the background and what is hoped to be achieved by that, you'll see that it's perhaps different from what you might have interpreted from just reading the recommendation.
Thank you, Barbara. Any other comments or questions? If not, we'll move to a poll on this one. Okay, so this one will move to the June slate for the public comment. Next is building anchor partnerships with academic institutions. Comments or questions from those in the room? I'll say, Barbara, I'm recollecting that we had changed the language of this recommendation to focus on the kind of the academic health department framework model, but I may not be recalling it correctly. So is that a separate recommendation or is that?
No, that's what this one was converted to.
Yeah, I thought we changed the language. This is Maura.
Yeah.
So we're looking for that in the moment. We may need to.
Let's do that.
Okay. Okay, I think we're gonna, if in the interest of time, and apologies for the discrepancy here, just because we've got 12 minutes left. Let's table this for the next meeting because there was a different set of language that was submitted later about this recommendation. And we'll need to get that up on the screen in front of the commissioners and sent out ahead of time. So let's move to the workforce work group. And Shane is going to read out the recommendations and we'll cover whichever ones we can get through. And I believe Brian, if he's still on, he was on the meeting. Are you still on, Brian? Okay, great. Thank you.
All right, first is WKF 037, ensure full access to state job classifications for local health departments. The recommendation reads, the Maryland General Assembly should require the Department of Budget and Management to grant local health departments full access to the complete range of job classifications within the state personnel system. This includes access to higher grade classifications commonly used in other state agencies. WKF 038, dedicated public health job classification system for state and local health departments. The recommendation reads, the Maryland General Assembly should require the Department of Budget and Management in collaboration with the Maryland Department of Health and local health departments to establish a distinct job classification system tailored specifically to the needs of the governmental public health workforce, including both Maryland Department of Health and local health departments. WKF 039, support full implementation of the 2023 State Personnel System Task Force recommendations. The recommendation reads, the Maryland General Assembly and executive branch agencies should prioritize the timely and full implementation of the recommendations outlined in the 2023 State Personnel Task Force report. WKF 040, commission a study on human resources reform to strengthen local health department autonomy and explore an independent human resource system for Maryland Department of Health. The recommendation reads, the Maryland General Assembly should authorize a comprehensive study to examine reforms to the state's human resources system with two primary goals. One, increasing autonomy and authority of local health officers as agency heads and operational leaders. And two, evaluating the feasibility of establishing an independent human resources function for the Maryland Department of Health, modeled on agencies like the Maryland Department of Transportation. Finally, WKF 041, Bureau of Local Health Department Assistance and Support to strengthen coordination across Maryland's local health departments. The recommendation reads, the Maryland General Assembly should authorize the creation of a Bureau of Local Health Assistance and Support in the Office of the Secretary within the Maryland Department of Health to serve as a technical assistance body for the state's 24 local health departments. This bureau would not direct or oversee local operations, but would facilitate cross-jurisdictional collaboration, elevate common challenges, and promote consistency in public health practice where appropriate.
Great. Thank you, Shane. We'll go back. Oh, sorry. Yeah, we'll go back to the first one. For the workforce work group, which is ensuring full access to state job classifications for local health department. Any comments or questions from commissioners in the room? Comments or questions from commissioners online, if you could raise your computer hand. Dr. Rossen?
Yeah, hi. I guess I'm just wondering how 037 or I guess 038, the next one, they seem a little contradictory. Because the other one I think says you're going to create classifications unique for public health. I'm obviously paraphrasing, but yet this one says, which I totally understand, includes accessing the complete range of job classifications. So is there one we prefer?
I think they're separate recommendations. One is the now, and the other is to work on developing a future public health jobs classification system. But really the thought of this one, and I'll let Brian speak too if he's interested, was that local health departments should have access to the full range of positions, whether you use the now system or whether you use the future system. Local health departments should be relegated to the lower level positions just because, it's decided that they get lower level positions and the state get higher level positions.
And even in a future system, you would need to designate that you have the full option of that future system. So I think these are two bites at the same apple from different sides of the apple.
Okay, thank you.
Thank you. Any other comments online? Okay, let's move to a poll on this one. Okay, this one will advance to the June slate. We'll move to the next workforce recommendation. And this is the dedicated public health job classification system as we were talking about. Any questions or comments from commissioners in the room? Okay, how about commissioners online? You could raise your computer hand if you want to speak. Nilesh?
Just a rec. I think this is fine. I think in Amelia, by the way, I just want to take a moment to say that Dr. Aria's recommendations and synthesis were excellent, and I want to thank her and that team for that job that they did. Kudos to them. And I hope we're incorporating their recommendations into our work groups and the work that we're doing. That said, I think one of the recommendations from there is, I think, probably a better formulation of this, and just want to put a note out to maybe revise that with that recommendation from their set. But otherwise, fine.
Thank you. Any other comments or questions online from the commissioners? Okay, let's move to a poll on this one. Okay, this will advance, and we're going to advance to the next recommendation. This one is about implementation of the existing task force recommendations from the State Personnel System Task Force that studied all this. And any comments or questions from commissioners in the room? Okay. Comments, questions from commissioners online? None. Okay, we'll move to a poll on this one. You guys are rocking it. We're going to advance this to the June slate. And if there are any ongoing concerns, please raise those at the June meeting when we reconsider it. Okay, next one is the commission, a study on HR reform to look at strengthening LHD autonomy and exploring an independent HR system for the Maryland Department of Health. Any commissioners in the room who would like to comment or have questions? How about online? All right, I see a visual hand from Chris. Great. Go ahead, Chris. Go ahead, Chris, if you're ready to talk, or if not, no worries.
This is let the health departments each have their own system, or oh, I see. So if this is let health, because I'm just wondering whether this is going the opposite direction of what we were suggesting with the electronic health records.
Yeah, no, this is, the health department, not all health departments use the state personnel system. Of those health departments that choose to use the state personnel system, this would, number one, would increase their ability to implement state personnel system transactions without having to go through, 5 layers of approvals and the delays that then causes. And two, evaluating whether or not the MDH could have a level of independence within the existing HR system, similar to what the Maryland Department of Transportation has, so that they also don't have as many levels of layers to go through and executing personnel decisions. So, Dr. Levy, okay, Matt?
Yeah, I have a comment. This is going to be pretty problematic for the home rule counties, because we have also the HR system from the whole county. So if we're gonna have, but we don't have great access to the state one. So it's kind of a strange relationship. And I don't know if we can be, even if this was passed, I don't know if we could be independent of our county and independent of the state. I think it's be confusing, very hard to pull off.
So this would just, I believe, apply to those who are using the state human resource system. And if you're using not your county human resource system, if you're using the state's human resource system, then it would allow you a level of autonomy as an agency head to make HR decisions within the state human resource system. This would not apply to your use of your county human resources.
So Mina, can I interject here?
Sure, go for it.
This is not making any changes. This is asking to answer the question that you just brought up. It's for a study to examine these intricacies. So this has been a consistent, the HR issues have been a consistent pain point in every conversation we've had with local health officials. And so this is really, we're going to need lawyers, we're going to need home rule, we're going to need non-home rule, but let's study it. Let's put the energy into saying, we got to look at this and come up with a solution. But it changes nothing with its passage per se.
Thank you, Brian, for clarifying that. I was jumping ahead. A little too eager. All right, any other comments or questions online? And this will likely be our last one that we'll consider at this meeting. Okay, all right, let's move to a poll. Yeah, we have quorum, so. We have one more.
I'd like to put a motion in that we extend our meeting by 5 minutes so we can complete the work group and therefore relieve Brian of any further tasks.
There may be more.
There may be more recommendations, I understand, but at least to relieve them.
Is that
Motion for 5-minute extension so we can complete the working group's proposals.
everybody okay?
A second.
All right, we're good. Is everybody online okay? Are we still maintaining quorum? Okay, all right, we're gonna keep going for the last recommendation. That one passed, by the way, to the June slate. Thank you, everyone. Thank you. All right, we'll go to the next one, which is
041 Bureau of Local Health Department Assistance and Support to Strengthen Coordination across Maryland.
we might need to advance slide. Michelle, is it? No worries, thank you. Okay. Any comments or questions from commissioners in the room? And I'll make the comment that there's the level of the secretary was important for this, just because the local health departments, the work they do goes beyond a particular area of MDH and includes the behavioral health area, Medicaid, public health services, et cetera. And in order to ensure the responsiveness of all areas of MDH, we thought the level of the secretary would be an appropriate location for this technical assistance body. If no other comments or questions from commissioners in the room, any comments or questions from commissioners online? You could raise your computer hand. Okay, Nilesh?
Understanding this, I think that you'll find that since the bulk of the work does happen in PHS, this is going to be a tough one to execute. That's all I'll say. There needs to be a level of practicality in this one as well. But the other note that I'll make is that I don't see MACHO being referenced here at all. And I think that part of MACHO's function is actually to do some of this. So curious as to where that conversation has been.
So I can, if you, MACHO is a, private membership organization. It's not a state agency. This does mirror several other states. You look at the state of Texas as a regional local health services. It's really to give a voice that is unique to the local health officials within the broader bureaucracy, so that if there are common issues, if there's a way to facilitate cross-jurisdictional collaboration, these can be brought up at an equal level and not at a subordinate level to other issues within a state system.
Thank you, Brian. Any other comments or questions from commissioners online or in the room? No? Okay, we're going to move to a poll on this one. Thank you. All right. Okay, that one is going to advance with the June slate. Thank you all commissioners for agreeing to extend our meeting by 5 minutes so we could get through all of the recommendations. I know one will come back to us after it gets revised by our team, and we'll see the additional new recommendations, I'm sure, at the next commission meeting. Our next commission meeting is scheduled for Thursday, May 20th. It's virtual, scheduled for 1 to 3 p.m. And again, the revision to the September commission date will be sent out by calendar, and that'll be for September 25th from 2 to 5 p.m. in person. And then I will call for a motion to adjourn at this time. Thank you. Any seconds?
Make motion, second.
All right, great. Any commissioners all in favor?
Aye.
Great.
Aye.
Aye. All right. Wonderful job, everyone. Thank you so much. Thank you to all the work group members and the work group co-chairs who participated today.
Thank you.